everyone, and welcome back to another video on the channel. Welcome back. We're going to go over now the third episode of infectious disease questions from the ABIM Internal Medicine Board Exam, and these are all high yield educational objectives and medical concepts that have been tested on the boards and are on a lot of different resources such as UWorld, MKSAP, and ACP. As well as Ambos. So we bring these educational objectives in, and we use different types of AI to create our own questions and then break them down and analyze them in a way to help us remember them better. So we're gonna go ahead and get started today and go from there. If you guys like the episode, enjoy everything we talk about today, make sure you drop a like, subscribe, comment, and let me know what you like and what you don't, and if you thought this episode was effective. And another reason we do these videos with different AI tools is because we're moving that everything is going to become automated and artificially generated. We're to less likely be paying for resources and as such. So if we learn how to create our own questions and learn from it, we'll be getting ahead of the game. So Manus AI, as you know, I got early access just a few days ago, and I created a couple of series. The first one was the HEMONC, and then I did a physician efficiency series, and now I'm doing the infectious disease questions using Manus. And as you know, Manus is a Chinese company, and they're very well known for the ability to multitask and be able to actually monitor. You can see their monitor when they're generating answers and questions and where they pull it from. And another options that this Manus offers is the fact that it will create knowledge, basically information, or kind of like a knowledge memory of things that you feed it, and it would really personalize to your needs. And I'll go over how you can personalize it better, and also what to do with your GPT to make it more personalizable, especially directed to your needs as a physician, resident, medical student, whoever you are. So let's get started. This is a 32-year-old man who presents the emergency department in July with 5-day history of fever, severe headaches, myalgias, and fatigue. He reports camping in Connecticut 2 weeks ago. On exam, his temperature is 39.2 degrees or on 102.6 Fahrenheit. Blood pressure 110/70, pulse is 102. He has a circular rash with a central clearing on his left thigh. Okay, so all the way till here, the months are important, right? You got the July, you got a Connecticut, and you got a central clearing rash. So you should have a kind of a preliminary diagnosis of what you're thinking about. Lab study shows WBC 30.2 with 80% neutrophils, hemoglobin of 13.5, platelets 95,000, mildly elevated AST and ALT in 78 and 92 respectively. Which of the following is the most appropriate initial management? So go ahead and pause the video right here, pick your answer, and we're going to go over the options. All right, as you know, I've created a way where we analyze options together. So the first thing I call the 5-step method. So the first step is to understand pathophysiology, because really you will realize if you understand pathophysiology, you won't have to memorize. So pathophysiology-based understanding. So this is HGA actually. So this is important. It wouldn't really affect your treatment, but we'll go over how boards could ask this. Maybe they could ask a diagnostic question, then that would affect and give you a few options. But what I want you to always have on your diagnostic kind of radar is this diagnosis as a co-infection, and the other co-infections associated with Lyme disease, because everybody was able to tell this is central clearing on the left side, this is Lyme, right? So but if this question was in a way was asking for diagnostics and you empirically treated, then you would have missed this one. Okay, so HA is caused by anaplasma, phagocytophyllum, an obligate intracellular bacterium that infects the neutrophils, creating characteristic murulae or microcolonies. It disrupts the neutrophil function and cellular apoptosis, causes cellular apoptosis. It causes leukopenia, thrombocytopenia, and hepatic inflammation, which is what actually make it different from what Lyme disease causes, right? So without that, you wouldn't have to suspect that this patient had HEA, but you had a specific central clearing rash that was Lyme, But then leukopenia, thrombocytopenia, and hepatic inflammation are not usually typical of Lyme. So then that you should start thinking about these co-infections. So this anaplasma is also transmitted by Ixodes scapularis tick, the same vector for Lyme disease, which is that's how it is. And Lyme disease is, Borrelia burgdorferi. It occurs, this co-infection occurs in 2 to 15% of cases due to the shared vector. And the erythema migrans rash is characteristic for Lyme and not HEA. So again, be able to tell which one is which. This is where it's a little more involved compared to step 1 and step 2 and step 3 even. They're less likely to try to have you distinguish based on these findings. So becomes a little more clinical, as you can see. When you go through the key clues, summer presentation, right? Flu-like symptoms, recent travel to Connecticut, which is an endemic area for tick-borne illness, the erythema migrans, and then the characteristic stuff with HEA, which talked about leukopenia, thrombocytopenia, and transaminases. And so the options, really the correct option was going to be oral doxy. It treats both of the Lyme disease and the HCA. Amoxicillin, of course, is an alternative for Lyme, but would be ineffective for HEA. And acyclovir would be for viral infection. Ceftriaxone may work for Lyme, right, but not optimal for HEA. So again, becomes very important. If let's say you were to treat only Lyme and the patient could not tolerate doxy for that reason, and then you wanted to have to cover for HEA, and if you really didn't know that this patient had HEA and tried to treat with ceftriaxone, the patient would have been inadequately treated, and then would lead to serious complications of HEA if it remains untreated. This is the third step of the 5-step method, the algorithms for clinical decision making. So assessing for specific syndromes. First, easy. Erythema migrans rash, think about the Lyme. Flu-like illness with cytopenias, think about either anaplasmosis or ehrlichiosis. Remember the other co-infector. If you had a picture with hemolytic anemia with history of a splenectomy, especially you would think about babesiosis. And but again, another way you can distinguish between these different types of tick-borne illnesses, and kind of like if you can think about what also causes which ones affect the white blood cell lineage, so like the neutrophils in this case, for example, versus which ones affect the red blood cells. And then you would find, for example, for babesiosis, if you remember, would be the Maltese cross and then the intra-erythrocytic inclusions, right? So they would be in the red blood cells. Anyway, going back to this, consider co-infection. If the mixed clinical features present, think about the endemic area exposure, atypical presentations of single disease, and then think about the treatments. As you can see, anaplasmosis, ehrlichiosis, doxycycline only. Very important to know that Lyme could be used here, any of these. Suspected co-infections must have doxycycline. Diagnostics, testing. You can initiate the empiric treatment while awaiting results. You could do a blood smear, very easy. You could do a PCR, and there's also acute or convalescent serology that you can order. And again, it kind of goes over the pattern of how each of these diseases can present. And the latest American guidelines, this is the IDSA, perfect, and the Center for Disease Control. And really, in my instructions to it, I told it to pull from the American guidelines. So it was able to detect that what I mean is American societies such as infectious disease, as well as the Center for Disease Control. So it went and actually got all of those. And it gives you a little more details, right? So empiric treatment would be doxy. Adult dosing is 100 BID for 10 to 14 days, and treatment should not be delayed. And again, talks about how it's effective against other tick-borne illnesses. And then it also gives you details. So in the first week, a PCR would be the best for acute illness. Peripheral blood smear is good, but you may miss it. Acute and convalescent serology, 4-fold rise in titer. And then the complications of untreated anaplasmosis would be respiratory failure, renal failure, neurologic complications. So mortality was 0.5 to 1%. And for a patient with a clinical lab test such as HGA and Lyme, prompt initiation. So don't wait for the diagnostics. Go ahead and treat. Okay. All right. So if you enjoyed until this part, don't forget to drop a like, comment, subscribe. Let me know what you like. Let's move on to the next question. So this next question is a 58-year-old man with a history of alcoholic cirrhosis. He presents to the emergency department with fever, abdominal pain, and rapidly spreading erythematous rash on his right thigh. He reports eating raw oysters at a seafood restaurant 24 hours ago. Okay, so right till here, you should have a diagnostic, idea of what we're talking about. On exam, he's got a very high temperature, 103. Blood pressure is low, 90/50. Pulse is 120. Okay, so signs of shock. His right leg shows erythema, edema, and several hemorrhagic bullae. So this is, again, telling you the diagnosis. Labs studies show leukocytosis, thrombocytopenia, elevated liver enzymes. Which of the following is the most appropriate initial management? So go ahead and pause the video right here, pick your answer, and we're going to go through the question together. All right. So, let's talk about what we have. Of course, this is Vibrio, right? Vibrio vulnificus, gram-negative, halophilic bacterium. It produces multiple valence factors and then rapidly multiplies in iron-rich environment. Very important. So this patient has history of cirrhosis. They could tell you the patient has hemochromatosis. They could hint to hemochromatosis. On boards, the question will not be as obvious as this. This is made for us to see all of the kind of presentations that could be in board. You may give 3 of the 5 presentations and then added 2 or 3 more distractors on top of it, as we have talked about this before. Causes systemic infection via 2 routes: wound exposure or gastrointestinal ingestions. It triggers a fulminant inflammatory response leading to septic shock and tissue necrosis. So in a patient with liver disease, the bacteria can rapidly proliferate due to the increased serum iron levels and reduced immune function, causing severe septicemia. Mortality rate exceeds 50% if not promptly treated. Now, this patient had all of the clues for you to understand or find out this was Vibrio. Alcoholic cirrhosis, raw oyster consumption, fever, hypertension, tachycardia, hemorrhagic bullae, and rapid onset. And then when you went through the options, you just have to know that you need the IV antibiotics, right? So you need the Rocephin and Doxy, which would be ceftriaxone and doxycycline. But remember, this is neck fash and hemorrhagic bullae. So you need to also pick surgical debridement, just with any other neck fash, right? Because this is a very rapidly progressive infection and the patient could die. So that was the option there. And again, going through these steps. Now, algorithm, when you see someone with liver disease, hemochromatosis, immunocompromise, history of raw shellfish exposure, seawater wound contamination, like a fisherman, especially, I'll tell you from my experience here in Texas, we have a lot of people on boats and fishing and they're standing in seawater. They come in with this infection. This is very actually high on our differential diagnosis because we do have a kind of like a lukewarm seawater, perfect for this specific bacteria to grow. And so anyway, when you assess the risk factors, evaluate for the sepsis, examine for the characteristic skin lesions if they're there. Very important to find out these, find them, look good, get a good skin evaluation on your physical. Immediately start the doxycycline and third generation cephalosporin. Call for a surgical evaluation for the debridement, and then this patient most likely will require ICU. Very important to have appropriate level of care, as what we say in the hospital. Get your pan cultures, blood, wound, stool cultures, everything if you need to. The patient has sepsis with characteristic skin lesions requiring both antibiotic and surgical intervention. And then pattern, again, kind of repeating what we were talking about. Very rapid onset, right? 12 to 72 hours. And just think about this immediately. Latest American guidelines for diagnosis. Again, It went over this time CDC and IDSA again. Doxy, they are talking about IV twice daily plus a third generation cephalosporin, which would be ceftazidime or ceftriaxone, as we call it more commonly Rocephin. Alternative could be fluoroquinolone plus a third generation cephalosporin. Early surgical consultations is essential. Prompt debridement, very important for survival, and sometimes may require repeat debridements, so which is very important to consider. The supportive care, always aggressive fluid resuscitation, vasopressors, ICU monitoring. So high-risk individuals should avoid raw undercooked shellfish. So let's say if you have end-stage liver disease or cirrhosis or have hemochromatosis, immune compromise for any reason, I would highly recommend these patients or to stay away from raw or undercooked shellfish and avoid also seawater exposure if they have open wounds. Very important. Okay. So that's the correct answer. All right, let's move on to the next question. So I want to make sure I don't give away the answer. Okay. So this is a 28-year-old woman. She's planning a 2-week trip to Mexico in 1 month. She has no significant medical history and takes no medication. She is concerned about developing traveller's diarrhea during her trip, and she requests advice on prevention and treatment. Which of the following is the most appropriate recommendation? So basically, they're asking you what are the prophylactic antibiotics, if indicated, for a patient going to a 2-week trip to Mexico. So go ahead and pause the video right here, pick your answer, and we're going to go through the options together. All right. So this goes to a little bit of a memory kind of thing. So traveller's diarrhea is very important, right? So what are the common bugs that we talk about? Usually ETEC, right? Enterotoxigenic E. coli. They produce the heat labile and the heat stable toxins that increase intestinal CMP, CGMP. You remember those from the good old sketchy days, leading to secretory diarrhea. Then we have also the enteroaggregative or EAEC, which forms biofilms and causes inflammatory response. Other pathogens that you can see with travelers would be Campylobacter, Salmonella, Shigella, norovirus. And so the pathophysiology varies really by the organism, but generally involves some sort of a bacterial adherence to intestinal mucosa, toxin production, right? And inflammatory response in the epithelium, then altering the gut motility, causing secretion and things like that. But for this question, so you have a healthy young adult traveling to Mexico, which is a high-risk area for travelers' diarrhea. They want something for prevention and treatment advice, and there's no contraindication to standard therapy. So let's analyze each of these options. Option A was daily Cipro, right? So this would be incorrect because antibiotic prophylaxis is not actually recommended for routine travel. B, they were saying about prophylactic loperamide. So again, remember that these bacteria can produce toxins, and we don't really want to give in a severe infectious diarrhea. We don't want to give them antimotility agents because they can actually contribute to worsening. Azithromycin for self-treatment. Appropriate standby therapy if they do develop moderate to severe diarrhea. So it really is very important. Again, the grade of the diarrhea matters. It recommended azithromycin. And then bismuth salicylate alone, that's not going to help. Metro is not first line for any traveler's diarrhea. Remember, we use that in Giardia and OVA. And then the algorithm here is very important. So you kind of have to know geography, and there's no other way around it, right? So high risk areas, Mexico, Latin America, Africa, Middle East, Asia. Intermediate risk would be Europe, South Africa, Caribbeans. Low risk, US, Canada, the Western Europe and Japan. Prevention strategy, food and water precautions for all travelers. You may use bismuth subsalicylate for short-term prevention in select areas. Antibiotic prophylaxis only for high-risk travelers. But treatment algorithm would be, if you have mild diarrhea, which means 1 to 2 stools a day, you don't need to do anything. Just make sure you drink enough water. You're fine. Moderate diarrhea, when you pick up 3 to 5 stools a day, then you can consider adding the antibiotics plus or minus the loperamide we'll have to talk about that. And then severe diarrhea, definitely not the loperamide. And that's when you have more than 6 stools a day, fever, maybe blood coming out. And so definitely antibiotics there. Now, very, very important, board tested. You need to know fluoroquinolones are actually first line, except in Southeast Asia. So if somebody is going to Southeast Asia, Philippines, Vietnam, those areas, they cannot take fluoroquinolones because those areas have a lot of resistance. Alternative would be the azithro, and it's preferred for Southeast Asia, children, and pregnant women. Okay, so this will be there. Rifaximin is alternative for non-invasive diarrhea. And so the standard approach for a healthy person, traveler, no routine antibiotics for prophylaxis, self-treatment with antibiotics only for moderate to severe, fluoroquinolones for most destinations, azithro specifically for Southeast Asia, children, and pregnant women, anti-motility, agents as adjuncts, but not as sole therapy, and do not use in severe diarrhea, blood, or any red flags with the diarrhea, which can actually cause the toxins to be retained and increase the risk of worsening infection. So in generally, don't recommend it unless it's just very mild. Bismuth subsalicylate for prevention in select cases. I have not seen that board tested multiple times. When you see healthy traveler, high risk area seeking advice, standby antibiotics for self-treatment, only moderate severe. Okay, so that's the key takeaway. And this is again the latest guidelines. The antibiotic prophylaxis is generally not recommended, except for high-risk travelers, IBD, immunocompromised, and where risk of adverse effects and antibiotic resistance outweighs the benefit, of course. And then the standby self-treatment appropriate for travelers to high-risk area, initiate for moderate to severe diarrhea. First line, fluoroquinolone, azithro, and then rifaximin. Azithro preferred for Asia, Southeast Asia, due to the quinolone resistance in that area. Loperamide can be used by antibiotics for non-bloody, contraindicated in bloody diarrhea, fever. Should not use as sole therapy in a moderate to severe. And this is a cool one. So prevention strategy is probably from CDC, this one. Boil it, cook it, peel it, or forget it. Okay, boil it, cook it, peel it, or forget it. Bottled or treated water, including ice. Hand hygiene, and may reduce risk but has limitations. Yeah, that's it. Well, I hope you guys enjoyed the video. I know it kind of long and there was a lot of information, but I think it grasped all of the things they could be tested on these. The way the board is going to try to get us on these ones is by asking next step or trying to give you a variation when there's a pregnant woman, or they're trying to give you a variation where the patient goes to a different, like Southeast Asia, and then you just have to know that the antibiotic will change there. And the geography testable, the first line testable, the loperamide testable, right? So they could try to get us on those things. Anyway, I hope it helped. I'll make sure you guys drop me a comment, a like, subscribe. Give me recommendations on what kind of questions you want to see. If you want any difficult topics you want to break down, we'll go ahead and use different AI tools and make it as easy as possible and understandable. That's the goal. And I'll see you guys on the next one.